right. Hey, everybody. Hope everybody is doing well today. We're super excited to have you with us. And today we are talking about seizure action plans. And I think most of you probably have heard of them, but at times this is not something that's always brought up by healthcare providers. And we want to make sure that we give everyone an opportunity to learn a little bit more about them and how they work. So I'm also trying to Facebook Live this, but it is looking a little bit like it's my first time doing it, and it's showing to the wrong profile. So I might have to scrap that if I can't figure it out in just a second. Let's see, while I'm trying to figure that out, I'm going to do a little bit of intro talking about just kind of what we've got going on today. So I think here it is. One second. There we go. Okay. I think we're doing cool. Okay, I think I'm doing it, and we will find out in the end if that's happening. So thanks for your patience, everyone, as I learn technology. But anyway, today you are here today because we are talking about seizure action planning, and in particular about summer. So we all know that summer comes and our routines change, right? Maybe your kid's going to camp, maybe you have new caregivers, maybe there are heat is a feature or a trigger for a lot of kids. So we know that things change, and that's why we wanted to have a session talking about how to be prepared, right? And how to think about the triggers, new environment, new caregivers, and ensure that we have a plan in place to help us if there are seizure emergencies. So this is what you're here for today. We're super excited to be here with Marissa Bishop, who is mom to Gregory, 6 years old, who has CDKL5 deficiency disorder and is a board member for IFCR, the International Foundation for CDKL5 Research. She is also one of our top Deep Connections fans, a super fan. So I'm so excited to have her on with us on a webinar on the other side. Welcome to the other side, Marissa. And Dr. Ina Hughes. And we've worked with you before, Dr. Hughes, and we're really excited to have you back. She is an associate professor of child neurology and epilepsy at the University of Rochester, and also the new epilepsy fellowship program director. Congrats on that. Her clinical interests are in pediatric epilepsy and the ketogenic diet. And so we're really thrilled to have you with us. We last talked with you about seizure tracker and, seizure tracking, which is a really fantastic discussion. And so really thrilled to have you back with us today. I'm going to take this down, except for to say one last thing, which is that we did receive support from Neurelis to do this series. This is the first in the series. We will have one next week on the same topic in Spanish, en español, si alguien aquí se habla el español, but I'll save my broken Spanish for next week. But we're really grateful to Neurelis for supporting this, and our partners at the Seizure Action Plan Coalition, who I will talk about at the end a little bit more. But to start, I would love to go to you, Marissa, and hear a little bit about your experience with seizure action planning, how you've made that happen, how you do update that on a regular basis, and why you feel like it's a really great tool to have in your toolkit.
Sure. When my son started having seizures, he was an infant, and so he was home with me. And actually, I don't remember having an official seizure action plan until he enrolled in school. So when he enrolled in the public preschool program, that's when we did our first official seizure action plan. I think if I had had caregivers for him younger than that, that might have been different, because obviously anytime you leave your child in the care of someone else, they need to be aware of what to do in the event that they have a seizure. But for us, I was home with my son in his early life. And so our first official seizure action planning came when he enrolled in the school system. At first, it was a bit of an overwhelming process because you're not really sure what it's supposed to look like. And, the school has particular forms that they like to use. And it was really important to me to be a good communicator about what my son's epilepsy looked like. So, with kids with DEEs, they have lots of seizures, and my son has seizures every day. And so, and multiple types of seizures. So it was really important to me that I was an active participant in the seizure action planning process, because I felt strongly and still feel strongly that I am the best expert about his epilepsy, and the best expert about what his seizures look like, what his triggers might be, what are warning signs, how he should be comforted or positioned before, during, and after. And so when we went to make our official action plan, I was really the driver of that. When we're looking at the form, it's basically critical but somewhat simple information. So, a little bit about what his seizure history is, his significant medical history, and then descriptions of what his seizures look like. So the type of seizure, the intensity, the frequency, and a description of what people would see if he is having the different types of seizures that he's having, information about triggers, information about warning signs, and then what they can do to help him during the seizure, and then any aftercare that he might need. There's a period of time where Gregory was using oxygen after seizures, so he needed that monitored, and then, protocols for how much oxygen and what that should look like for him. But, going through the planning process, I really feel lucky that my primary neurologist, Gregory's neurologist, and the school nursing team really were collaborative with me to be able to make sure everything I wanted included, even those little things that, those little triggers that only happen maybe sometimes, or the little warning signs that, are really hard to pick up on, but that really people should be able to notice as they're knowing him and knowing him well. I would assume most kids with DEEs have somebody one-on-one with them at school. My son certainly does. He has a one-on-one nurse. So, helping to educate them about the benefit of my experience caring for him for so long, and making sure all of that benefit of my own experience is also reflected in the plan to make sure it's, it reflects everything that he needs, as if I was right there in the times when I can't be there with him. It's so important to have a seizure action plan for our kids. Absolutely.
Yeah, thanks, Marissa. It's really, I think you do an excellent job of explaining why it's important and how you develop it. And I think, for a lot of people who are having these transitions too, right, to make sure that this is ready. And like you said, if you have somebody who's a caregiver that you're passing your child off to, I know for me, that's like a huge fear, is that like, will they know what to do? Mm-hmm. And this is a great tool that says, hey, now you know what to do, right? This is how you can help. And I thought, it's really interesting. We were talking to before that you were talking about that, when our kids have seizures every day, right? Like you want to make sure that they're not just shooting diastat and
Yes,
nasal and
absolutely.
all of these different things right in there, when it's like, mm-hmm. No, don't freak out. This right. is the, this is the norm. And this is when you go into high gear.
Yes, right. Absolutely. What is an emergency for a kid like this?
Exactly. Defining that.
Yes. What is, when your kid first starts having seizures, you as a parent have never experienced this before. So you really rely on the neurologist to give you information about what qualifies for an emergency. Right. But over time, you learn what is normal for your kid, even though, it's not a great normal sometimes, but you learn what's normal, and then you really have to fight to educate people on what is normal for them and what is an emergency. Because you're absolutely right. You don't want people giving your children medications that are above and beyond what they might need.
Exactly.
Or calling an ambulance when it's not necessarily necessary.
Exactly. No, that's so important. And Well, thank you, Marissa, for sharing. That was excellent. And I know that we've got Hughes, who we're going to invite to come back on. And she is a really incredible pediatric epileptologist. And we're really thrilled that she's with us today. I think I'm just updating the settings here. And she's one of those epileptologists and pediatric neurologists that gets it and really works and spends the time with her patients. So we're grateful to have you with us today, Ina, to talk a little bit about seizure action planning, and why these transitions are so important to make sure you are prepared for. So I'm going to let you take it away.
Thank you so much, Gabby, and thank you so much, Marissa, because you pretty much covered all my major points for me already. And so now there's just, a couple of reminder slides to talk about these things. And thank you so much for the kind words as well. So I a little bit misunderstood the assignment, and I didn't talk necessarily as much about how seizure action plans and summer go together. But quite honestly, for those kids that are going to summer school, for those kids that are going to be transitioning in daycare or in their preschool programs, pretty much a seizure action plan is always a great idea to have. But one of the really great points that Marissa made is that you kind of have to know what the seizure situation is for your kid before you get there in the first place, right? Because to generate a seizure action plan, you almost have had to have collected enough data to understand that question of what needs to be intervened on, what doesn't. We have some kids where a 1 minute long seizure is so incredibly unusual for them because they're a kid who does 5 second, 3 second, 10-second seizures, that a 1 minute long seizure may herald a transition to status epilepticus, whereas we have some other kids who they aren't in trouble until they're in a 5-10 minute long seizure. And it really is variable independent to the kid. I want to acknowledge some of the really great resources that are available out in the world, and I'll show you those as I go through my talk. And if anyone has any questions, Gabby's going to be manning the chat to make sure that I don't miss anything or miss anyone. So as epilepsy families, you already know, epilepsy is common. You have a very large and wonderful and growing community because epilepsy happens a lot in kids, which also means that epilepsy happens a lot in schools, whether or not they recognize it or not. And so that means that particularly in the school setting, which is the one that I think that I end up writing seizure action plans for the most, we need to acknowledge kind of the setting that kids are going into and what are the concerns and questions that happen there. So one of the things that happens is that folks at schools, while seizures are common, to them, they are an unusual phenomenon, and they have all of these fears and concerns and don't know what to do with them. And so some of the most common ones that I hear is, every seizure causes brain damage, so we have to fix them and prevent them. That's not an accurate statement. Sometimes there's the risk that any seizure could cause death. That's also not an accurate statement for the majority of our patients. The biggest thing that people really, truly, when you finally dig down under all of the stuff that they're worrying about, is that they might do something wrong, either fail to intervene or intervene inappropriately that could cause harm to the child. And unfortunately and annoyingly, also to them, put teachers, schools, the situation wherever the child is, or into some sort of liability for that harm. More importantly, they could cause harm, and they recognize that. To me, to some extent, good on them for recognizing that they could cause harm, because hopefully that's a teachable moment where we can say, cool, let me give you the information that you need to not cause harm. As a practical aspect, sometimes seizures can interfere with learning. They certainly can disrupt the school day for the child and for others in the classroom. And sometimes kids can have cranky, miserable, uncomfortable behaviors that happen after a seizure because they feel miserable, cranky, and uncomfortable. And each of those things needs to be kind of addressed and dealt with. But most students with epilepsy, most school-age kids with epilepsy, most program-age kids with epilepsy can and absolutely should be able to participate safely in all aspects of their schooling, whether they're capable of participating in sports or gym activities, whatever the activity is to the best of their ability, as long as we have appropriate supervision, precautions, and plans. So how do we do that? We combat fear with information and education, and we identify the needs and we establish a plan. So pretty straightforward things that you do every day in your life. is first thinking about where your child is and what they need. This is written for kind of all comers of all different varieties of epilepsy, the DE community, as well as kids who may have 1 or 2 seizures a year, because quite honestly, when you get down to the basics, they actually are relatively the same. Kids may need to go to the school nurse for medicines or rest if they feel a seizure coming on or experience seizure activity during the school day. Many kids have side effects from medicines that can cause them to be tired, moody, less attentive. They may miss class time due to seizures, epilepsy workup and care with their physicians and with their team. They may have learning and behavior problems associated with their underlying diagnosis or with medication side effects, and sometimes even just the psychosocial stigma and issues in life dealing with having a chronic disease of any kind can impact how kids function in school and life. Kids may need seating accommodations. As Marissa mentioned, many of our kids with developmental epileptic encephalopathies will often need to have an aide with them to maintain that seizure safety, to maintain seizure monitoring, sometimes even just simple things for redirection if they are feeling a little bit less than themselves. And then they may need to have accommodations. They may feel embarrassed about their condition and may benefit from psychosocial supports. Before I go any further, I just want to make sure that, guys, are you seeing my slides? Because I don't see the normal green ring around things that I use.
Yeah, we see how do we meet these needs now?
Wonderful, thank you.
Yeah, sure.
So how do we meet these needs? So almost every one of our kids will end up during school-aged years, often starting with Committee for Preschool Education, with either individualized education plans, 504s, and then the Seizure Action Plan should certainly be part of it. So as Marissa was explaining, you as parents have unfortunately a huge Herculean task as part of this, which is communicating the person that you know best in the world to people who do want to know your kid very well, but also are going to have another 6, 10, 15, sometimes 30 kids that they're going to be also caring for at the same time. And so good communication that is well documented is one of the hardest things to do, but is also one of the most important things to do. So talking with school and sharing what happens around the time that your kid has a seizure. Working with whoever is your neurologic provider to make sure that your student has a seizure action plan, and that that seizure action plan is actually built into your IEP and 504 plans, specifically because that is a way to ensure that it is mandated that everyone who cares for your kid has to actually sit down and read that seizure action plan. I have worked with lots and lots of groups where the seizure action plan definitely exists. The nurse knows it by heart, and no one else in that classroom or in that school district knows about it at all. And that's unfortunately not helpful for kids. Most seizures are not life-threatening, but there are seizures that are, and particularly for our more complex kids, being able to recognize the time when it is time to take care of a kid with a rescue medicine, it is time to help a kid take a nap, transition to rest, give them an updated regular medication because it's time for their standing medicine, alert a parent, or call 911, are things that people need to kind of know where those steps of escalation are. After seizures, what do we do about people? What do we do when people are not feeling their best as they're in that process of recovering from a seizure? Are there safe spaces for kids to lay down, to rest, to recover after a seizure? And if there are academic requirements on that kid, after a seizure, they may not be able to meet those academic requirements until they are fully recovered. And is there a way that's built into their IEP action plans to allow that to occur? So what are the components of a seizure action plan? We've been breaking it down all the way kind of through, and I'll break it down into what it kind of specifically looks like as you're building this. One of the things that I can say that I actually now is going into being an epilepsy fellowship program director, I'm going to teach my epilepsy fellow, who will eventually hopefully grow up to be an epileptologist, how to write these, because no one actually taught me how to write them. And a lot of the information that comes from a combination of trial and error, and then a couple of really great resources that were created when I was a relatively young attending, and that I learned to draw from. So we learned kind of what are the components that definitely need to be in everybody's seizure action plan. So who is the kid and what are their needs and characteristics? What do their seizures look like? Are there triggers to be aware of or to avoid? Do they need to keep, what do they need to do to keep the kids safe during the seizures? What do they need to use for rescue? That always includes how much, which medicine, and then what are the rules to be used to give that medicine. And when do they need to call for help? When do they need to call EMS and send a child to a hospital? Because absolutely, kids, particularly with developmental epileptic encephalopathies, may, for them, safely have 50 to 100 seizures a day. That's not our goal, but there are some kids that is their baseline, and they can be fine. But on the day when they have 150 seizures a day, that's a bad day for them, and somebody needs to be alerted and something needs to happen to make that shift. And then what are the safety precautions associated with that specific child's epilepsy? So as I said, creating a seizure action plan, you as a parent are certainly not alone. This is definitely something to do with your healthcare providers, and to know that there are some actually really great and very useful tools that are out there, including the Seizure Action Plan Coalition that has amalgamated and brought together all of the different kind of seizure action plans that are kind of readily available out there. And I actually did not know this, but Seizure Plan Action Awareness Week is held in February each year by the Seizure Action Plan group coalition. And we will definitely be celebrating that this coming year. To us in our division, it pretty much always happens somewhere around June for the summer school folks. And it then happens again in August, where we spend pretty much all of our time in our epilepsy care practice working on generating those seizure action plans and updating them for the coming school year. All right, so let's break out the individual components of the seizure action plan and what they look like. There are some great, simple, and easy fillable PDFs that are available out there, but for many of our DEE families, quite honestly, the boxes are too small. And for my own patients, I tend to use a format that we've created here that contains all of this information, but is something that we can more easily manipulate in our electronic medical record to provide as much information as is needed for our families and our kids specific to schools, and then to tailor it later in case it turns out that we have feedback from either the school that they need additional information or there's been a change in seizures, for instance. So for a relatively simple seizure action plan, for instance, making sure that it's up to date is a good idea. Making sure that we know who we're talking about their average weight and height at the beginning of the school year, which of course can fantastically change for some of our kids. Making sure that their general diagnosis is known and reported, any allergies, and what their general current medicines are. This is just sort of setting the stage. Who is this person that we're talking about and what is their baseline? So kind of the next step is actually a really important one. What do seizures look like and what triggers should people be aware of and should they avoid? In the Seizure Action Plan Coalition version of this, we talk about before a seizure emergency occurs, what is the context? What do people need to know about this person's epilepsy and how to prevent them from having that big, bad, long seizure or the cluster of seizures that may negatively affect them? Are there patterns and triggers that are fairly common, like onset of menstruation, fevers, flashing lights for some of our kids? We have some children that have very specific triggers, like looking at the sun or loud noises or sudden changes in temperature. And each of those things should be documented within the seizure warning signs or triggers. Again, one of the reasons that we very frequently don't use these wonderful printable seizure action plans is often many of our kids will have multiple individual seizure types. And for someone who typically has a 5-second tonic seizure, that may never need to actually be acted on other than making sure that the child is safe. But people need to know that that is a seizure that they can maintain safety, but not necessarily need to escalate to a rescue medicine, not necessarily need to escalate to a call to a family and go, they've had a quick tonic seizure, because that may be part of their daily norm. And so making sure that people understand what the seizure type is, what the length, the frequency, and the description is important. One of the things that's also important is how you communicate, sort of like when we were talking before about seizure tracking, making sure that it perfectly fits with epilepsy nomenclature, a tonic seizure, a clonic seizure, a myoclonic seizure is way less important than what you guys as a family call them, because I've had families say, well, there's the quick one, and there's the stiff one, and there's the staring one. And if that's the primary communication that you are going to have with school, actually putting that as the seizure type that you're talking about is really important. The other really important thing is making sure that someone knows what it looks like, so that even though they may have a different name for it, if they see the one where the body gets all stiff, or the patient stares off, or that they have lip smacking and they turn blue, each of those pieces of information will help them to make better decisions about what to do next. So the next is, what do we need to do to keep a kid safe during the seizure itself? So there is a variety of kind of general basic first aid information. And one of the reasons that I like this one from the Epilepsy Foundation was that for pretty much everybody, it gives these rules, including stay calm and track time, keep a child safe. And as Marissa mentioned, that idea of what is safe for each individual child can be very different. Some kids should never be placed on their back. There are a small number of kids where that's actually the place where they're going to be the most comfortable. Most people, we want to put them on their side when they're having particularly convulsive seizure. We definitely want to make sure that people know that they shouldn't be restraining kids who are having seizures, that they shouldn't be putting anything in kids' mouths. And they should know what it looks like as a kid recovers from the seizure and when the seizure is actually over to the best of their ability, because we also have kids who have very clearly ended their seizure, but they're still not themselves, and people will count that post-ictal after seizure period as still part of the seizure ongoing, and they'll get extra rescue medicine when they wouldn't necessarily need to. In general, there are some rules that pretty much mean everybody probably should get medical attention beyond just their rescue medication. And that's certainly if their rescue plan is being met and there's no one available to give that rescue medicine, or that rescue medicine isn't available to them, that's a great time to call EMS, to call 911, because then there are people coming with rescue medicine that may not otherwise be available to that kid. If they're having convulsive seizures that aren't responding to their rescue medicine, if they are having impairment in their breathing that is continuing after the seizure is over, if they're having back-to-back-to-back seizures that also aren't responding to their rescue medicine, pretty much in every situation, it is the right answer then to call EMS. Because then you have a backup set of hands and a backup set of medical assessments to help to determine whether or not a kid needs additional help. And importantly, it's also worthwhile noting that you don't automatically have to send your kid to the hospital if EMS arrives. Nowhere, anywhere in anybody's policy should ever state that if a kid gets their rescue medicine or EMS checks them out, they now have no choice but to go to the hospital. That doesn't make sense. Those should be continued communications between you and school and EMS as well. We talk about this being a great place to actually put what to do, for instance, if the child has a seizure associated with injury or a seizure associated with needing to change their location. Some schools have even requested that we put in, what do we do if the child has a seizure and there's a fire alarm? How do we manage that? And so letting them know that they can transport the child outside of the classroom in a safe manner, and that they actually have the tools to do that. Most schools do have the tools to do that. Sometimes it even has to be explicitly stated what to do when they need to transport a child out of the classroom. So when do they need to use the rescue medicine, which dose, and what rules? Particularly for our kids with DEE, many will actually have different seizure action plan rescue plans depending on the type of seizure they're having. If they're having lots of really tiny, brief, acute, repetitive seizure events, that may be something that we can then spread out and improve with something like oral or enteric clonazepam. Sometimes there are some kids that we give an extra dose of their standing rescue medicine. But when we're talking about things like continuous convulsive seizure, we're almost always talking about using medications like Diastat, the newer intranasal versions of midazolam, which is called Nasolam, and diazepam intranasal, which is Valtoco. There are a couple of new products that are trending towards the market, but not quite there yet, including a gel strip that includes rescue medication in it. And then some of our centers will use buccal or intranasal midazolam or lorazepam that can be delivered by just squirting into a syringe and squirting it into the cheek, or using a nasal atomizer to put it into the nose. Because these are controlled substances entirely, the only way that they're going to be available at school is for them to be present by doctor's order. And that order often has to look a very specific way, including the doctor's DEA number, their NPI number, or their license number, depending on state. Admittedly, it has to look like an order, which gives specific dosing instructions, specific situations in which it's given for. And then very often it also has to be protected in a lockbox, stored in specific locations in schools. And those can actually sometimes be different depending on the different school districts and states where you are. And so that's something to talk about and investigate with your team. Even though some of our kids may need their medicine on a really fast basis, it's not always available to them because of some of those rules about where that seizure medicine has to be kept and which type of person. So does it have to be an RN? Can it only be a LPN or above? Can it be anyone who is a good Samaritan? There are different rules per state about who can actually administer the medicine and when. If the child has a vagus nerve stimulator or has another form of neuromodulation, is there something that people can do to use that as a first line agent for managing medicine or managing status? And if that's the case, making sure that we let people know how to use that magnet, where it is and where it should go. Importantly, just throwing this out there for folks who have VNSs, make sure that people know they shouldn't be holding the VNS magnet over the VNS. We've had that actually happen several times recently. And I'm not sure why, but someone posted online that this is what you do. And we've had people turning kids' VNSs off during acute repetitive seizures, which has not been the greatest. And then it's important to make sure that people know that there are certain safety precautions associated with a child's epilepsy. So there are kind of some standard ones. We highly recommend that people who are walking and talking should not be climbing over 6 feet unsupported. We highly recommend, and mostly that means things like the big rope in the middle of the gym where they tried to have kids climb up to the top. If it's something that has soft landings, if there are pads, if those are safe spaces that are built for kids' falls, fine. You don't have to follow that. But otherwise, we think that there's some basic safety. Nobody should be swimming alone. Nobody should be on their own at high heights. No one should be around open fires. Hopefully that's not happening a lot at school, unsupervised. And particularly with kids with DEE, we hope that they are always appropriately supervised. And then there should be the provider signature, as well as an acknowledgement in some part of this that the family has looked over this as well. One of the things that I think is actually really important is that not all the kids are going to be in classic school settings. Not all of the communication that you're going to be having is going to be with a classic, trained RN. Some of them may be people at day camp. Some of them may be camp counselors. Some of them may be volunteers. And there are a variety of different versions of seizure action plans that can include, for instance, helpful illustrations to help people understand what to do. And so understanding how complex is this? How complex is the person on the other side of this? Is this a babysitter who has not a whole lot of experience with seizures? Then working to find the best way to communicate with them is always going to be a really great thing to do to make sure that you are helping to explain. One of the greatest things that has helped a lot of our families has actually been the smartphone, because they can take a video of their child's seizure and say, see, this is what happens during a seizure. And here's the place where you need to do something about it. Here's the place where you need to intervene when my kid looks like this, when this has gone on, when this type of seizure has lasted for this amount of time. And in general, when we've been able to show video for kids and be able to help people see this thing right here, this is what a seizure looks like, that's been a great improvement in overall seizure control and seizure management at school. As Marissa mentioned, seizure action plans should be living documents. In general, I say that there are 3 main rules of epilepsy, and one of them is seizures are subject to change without notice. And so because of that, seizure action plans should be updated pretty regularly. The Seizure Action Plan Coalition recommends about every 3 months. Some of you will see physicians in your epilepsy team as frequently as that, but some won't. But just a reminder, consider asking for updates of the seizure action plan if there are any changes in seizure type, if seizure frequency, seizure duration, if you have major changes in how your seizure medications are being given, or if something happens where you recognize, hey, you know what, this kind of cluster of seizures is ending on its own now with this particular set of meds in the situation. It doesn't require intervention. We're going to take that off of the seizure action plan for intervention and put it on the watch for this, but don't do anything kind of list, or vice versa. Now we know that if this seizure lasts, 2.5 minutes, it's going to keep going for 15, 20 minutes. So if we stop it before this, we can change that outcome. As Marissa mentioned, some schools and programs will have specific forms, and individual specific settings may require specific types of seizure action plans that match the kind of thing that is happening in that situation. For instance, I have a couple of patients with hippotherapy, with horse therapy, and helping them to understand when do we need to get the child off of the horse turned out to be kind of specific to the kid in the situation as well. So depending on a kid's epilepsy and a kid's inherent capabilities, there's always a question of, can my kid, and there's always, can my kid go to school? Absolutely. So the Americans with Disabilities Act and the IDEA education law specifically address that kids with epilepsy can go to school. And importantly, no one should tell you that your kid can't go to school unless that seizure action plan is present, and or that you can't send your kid to school if the seizure action meds, the meds are not there. Because in that case, should something happen, they should just revert to whatever their hospital, or whatever their school policy is for management of any kid with a seizure, which, by the way, every school should have a management plan for any kid with a seizure, because seizures are fantastically common in childhood. Can they go on field trips? Yes, that's one of the things a seizure action plan is for. It's making sure that a kid can change settings and still maintain a safe plan. Should you have to go with them to carry the rescue med? No, that's on the school to make sure that there is a plan that makes that happen. If you want to go on the field trip, awesome. But if you don't, school needs to have a plan for management. Can kids swim? Can they do other stuff? And the answer is yes, to the best of their ability, and with some additional supervision and rules, but to the best of their ability. So I'm going to stop there and answer any questions, and thank you again for this opportunity.
Awesome. Thank you so much. I think there's a lot of really important points in there, a lot of pointers to help us think through as we're kind of consistently working on updating those plans so that they are ready for any scenario. And I think, we know that schools are mandated to have, these plans in place. And I think summer it gets a little murkier. I think a lot of our kids, like I was talking with Marissa and Gregory, is going to ESY, extended school year. So he's still in the school and they still have the same mandate. And I think what's harder is if and when our kids go to other activities, and that's why it's really important. And I've talked to other families who do really incredible things where they will set up a training. They'll say, every year when my kid is a new teacher, I will go in and I will do exactly what you said, which I love that idea. Show the videos. This is what their seizures look like. This is how long they are. If it starts looking like this is when it's time. And so being really proactive about making sure that people who are around your kid get to know them as best as possible and be able to help intervene if the time is right, if that's necessary. So I guess I would love to talk a little bit more about summer and what some of the biggest triggers, tend to be. You talked a little bit about heat or change in temperature, and that's a big one. What are the kind of things that you work with families to put on there to make sure that, as summer comes, it's important to be thinking about? And Marissa, would love to hear from you too about what you think. Yeah.
So I gotta say, overheating is one of the biggest things for so many of our kids, from a combination of their own body physiology. A lot of our kids, particularly with developmental epileptic encephalopathies, may also have some degree of dysautonomia, which means that they're going to have difficulty with self-regulating their temperatures. Just for extra fun, some of our anti-seizure medications, classically zonisamide and topiramate, can also decrease sweating. Some of our kids are in wheelchairs. Some of our kids have kind of extra stuff like their, vests and their chest ravelers, which cough assists and all of those other things that in a hot classroom in the middle of the South, sometimes even the middle of the North, because half of our classrooms up here aren't even air conditioned, that it just, the kids overheat and they need to be kept in good temperature controlled situations. And so here in New York, there actually is a built-in rule associated with IEPs that kids who are temperature sensitive can actually get air conditioners put in their room to help to regulate their temperatures. And it's worth finding out if that's the case where you live, because if schools aren't inherently temperature regulated, sometimes that's necessary.
Yeah. Any thoughts, Marissa? And others, feel free to drop thoughts into the chat or Q&A. And
I mean, that's really interesting about the air conditioners. I would say this, it's a school's responsibility to make sure the environment is conducive to that your child's going to be safe and healthy. And, and, if there are needs like that, then definitely speak up about it. Like Gabby said, you have to be proactive with everybody. This is a good reminder for me. Like you said, Gregory is going to go to the extended school year program, and most of the staff is going to be the same, but there will be some new staff. So this is a reminder to me that I need to say to them, hey, let's review his seizure action plan. And then in terms of making changes for the summertime, anything that I would do personally with Gregory, like bringing an extra fan or bringing a cooling towel, or making sure I'm doing more water flushes, like any of those things that I'm going to do during the summertime to make him comfortable, there's no reason that can't go in his seizure action plan, because sometimes we never know what's going to end up being a trigger. Heat wasn't a trigger before, and now suddenly they're having a lot of seizures in the summertime. Well, maybe they need some extra water, maybe they need to get more shade. There's no reason any of that couldn't go in someone's action plan.
And Marissa, that's actually a really great point. So dehydration. So after just straight up temperature regulation, next becomes dehydration. So for those kids who are sweating, and particularly those who are G-tube fed, we are providing all of their fluids. And if they can't tell us that they're thirsty, that one of the things that you may see with just low-grade dehydration is an increase in seizures. And so then making sure that they have that for some kids, they are sensitive enough that you may need to talk with their GI team or their renal team or their dietary team about how much water to add extra. But that's a very important thing to consider for them as well. We have lots of families who have invested in those cooling towels. We have lots of families that just get spray misters. Those little spray mister bottles from the dollar store are really great for kids who don't have their ability to sweat well on their own, to just hose them down a little bit and cool them off.
Yeah, and the ones that are like a fan and a sprayer at the same time, those are awesome.
And also, just because we recently got one of these for one of our kids, there is a new neck fan thingy. It's like $12 from $12 from Amazon, but it's like a little cooling fan that is kind of right up here in the neck and head area. Awesome.
Yeah, we got one of those.
You did. Awesome.
Nice. Yeah.
It's like the next level upgrade from the spray and fan.
All these new things coming. I know that Maribel has a question. Go ahead, Maribel.
There.
Yeah, you're on.
I don't know if my video is working.
No, don't worry about it. You can just talk. That's fine. We can hear you.
Thank you. Well, I live in Mexico, and I'm Patrick's mother. He's almost 17, and well, I would like, he's had seizures since he was maybe less than a year. My question for you would be this. He takes a lot of anti-seizure meds, a lot. And now, a few years ago, the neurologist, who is an epidemiologist as you are, added also the cannabis oil. Patrick is extremely anxious kid, a nervous kid, ever since he was a very, very little one. And he barely sleeps. He has a lot of difficulty sleeping. so they did all these tests while on his sleep ever since he was very small, and he has all these activity during the night, and he always pulls his hands up while he's trying to sleep, and he moves all around the bed in a very strange way. And when he, the results on this polysomnography, I think it's called, they're always like on the very bad side, like abnormal on the 3rd or 4th grade. So he has never had, most of these are tonic, or most of them are absences. They don't last a lot, but a funny thing happens ever since he was very small. While he has these absences, seizures, then he never cries. He never cries. But suddenly there's this like a smile to the other side of his face, and then he starts having tears on his eyes, and he is completely I mean, he does not move at all. He cannot hear anything, but tears start falling down. Is this common on these kids? One question. And the other one is because of the seizure activity during night, he needs to have a nap, like 10 o'clock in the morning, and before it was like 3 o'clock in the afternoon, because he is completely tired. Does that happen to this kid? Is this often?
So yeah.
Go ahead.
Yeah, I was going to say it's a little hard to really get into specific treatment level questions with each patient, but I don't know if you have any general thoughts since you're not treating this child in particular.
Yeah.
But
so in general, in the answer of can it happen with a seizure? Yes. In the sense of whatever that question is, the answer is yes. And it's that observation that you have with when my child has a seizure, this is what we see, because epilepsy is fantastically individual. And so that experience that you have, that your child has specific, they cry after a seizure, they have tears, even if they don't necessarily cry, is something that we definitely see in epilepsy. And it's something that can be an important thing to communicate to someone else, is that he may look like he is distressed, but that's just what happens after his seizure if he's otherwise fine. When people are on lots of seizure medicines, when they don't sleep great, they need to make up that sleep somewhere. And it's pretty common that kids will have variability in their sleep cycles and variabilities of when they need to take rests and naps. Importantly, when kids are going to school, when they're going to ComHab, when they're going to different situations, making sure that people know, hey, this is what this kid needs. They actually need to take a nap during the school day to be able to function. Let's actually build that into their existence so that we're not making them even more sleep deprived. We're not making them even more tired, and we're giving them the best shot to have the best day at school and the best day at pre-K and the best day at program, whatever that is actually really important to communicate as well. Sometimes the seizure action plan document itself may need to be narrowed for the scope of where you are so that it doesn't include all those care instructions. We have some people who the seizure action plan only includes the rescue medicine information and nothing else. And we have something that is a bigger care plan that goes with a kid for just, and here's every other piece of information that isn't this rescue medicine information that you need. And that's really going to depend on your setting, and it's really going to depend on who you are communicating that information to. And sometimes you actually have to do duplicate information where you have, here is our grade of care plan. It says this is how feeds go, and this is how meds go, and this is how pulmonary toilet goes, and this is how you sit them up and feed them, and this is what PT you can and can't do. And here is what you do in an emergency. And sometimes that emergency can also be making sure that you know what to do when the G-tube gets pulled out, because that almost always seems to happen at school. What do you do when they are having extra snot in their trach, for instance, for trach kids? So those sorts of things. That kind of each body system that might have an emergency has a plan for that as well, particularly for our more complicated kids.
Yeah, that makes a ton of sense. I think that's really important that it's not just, I mean, seizure action plans are really important, but with really complex kids, there's a lot to be thinking about. So we had a question come in about swimming. You know, it's, I'm sure you get a lot of questions about that in summertime, but, you know, I think this one is a little different than should kids swim? And you already addressed that, which I think is great, you know, but I think with temperature regulation issues too, like kids who are really having chills in the pool, is that a sign that it's like time to get them out? Or is that like,
So I
you
have to
know,
admit, it's usually a sign that I use to get kids out, because that's the body saying I am in need of regulation, right? So in general, most of the time, most people are built that shivering shows you that their body is too cool for them and they're trying to warm themselves up by that extra muscle activity. There are some caveats to that, right? So kids with severe spastic CP, they're going to shiver kind of because their muscles are extra contracted, and if they get any extra tight, you're going to see myoclonus as opposed to shiver. And the slightly different is that myoclonus is going to be more jerky and it's going to be slower, and shiver is whole really fast and little bitty, right? But in general, if you're seeing shiver, that's usually a good indication that the kids may need a break, may need a warm up, may need to warm up the pool a little bit, or put an extra layer on them when they're in the pool as well.
yeah, I think that happens with my son a lot too, that he gets in the pool and he's just like, what is happening? And we also try to use those rash guards, right? Or the other things that just kind of help. Can't really do a full on scuba with it, which probably would be great, but something a little bit. What do you do, Marissa? You guys?
Well, I do notice that Gregory gets more chilly than I would think an average kid does. So we have a little spa that we use as a pool. That we keep it warm, you know, we don't keep it spa temperature because we use it as a pool, but we definitely keep it warmer than what a more normal pool is. But if he's shivering, yeah, it's hard to watch. So I take him out.
Yeah, I think that's good. There's a question about whether heat also affects the blood pressure. Is that something that's happening in summer with extra heat?
So yes, it's actually something that we'll see. A lot of our kids will end up seeming puffier. They'll have a little bit of edema in their limbs when they have lower muscle tone, because most people's body's response to heat, if they're getting overheated, is to try to open up those blood vessels to release some of that heat into the world. And so that's something that we certainly see, just like, for instance, in the deep winter up here in northern New York, we will see a lot of our kids with, again, dysautonomia associated with their DEEs. They'll have kind of not blue or purple, but they'll have cooler limbs. They'll seem a little bit tighter. The reverse ends up being true in the summer. They'll seem puffier. They'll seem a little bit looser skin, like they are a little bit edematous, and that's actually fairly common because you're trying to release some of that heat. And so that can also be a sign that the kids are getting too hot too consistently, and something that you can work on better temperature regulation when you see that.
All right, well, we're coming up on time here, and I want to make sure I have a quick minute just to share a few extra thoughts about seizure action plans. I thought did a beautiful job of sharing kind of a lot of different things, elements to think about and resources. I love the Seizure Action Plan Coalition website, seizureactionplans.org. And they have really terrific resources on there. This is loading up. They have a lot of resources, frequently asked questions, some background on seizure action plans, and then a bunch of different resources for people to call up when they're going through this process. So feel free to check them out and learn more there. Again, this is part of a series, so we're talking kind of today about summer, but in the fall, we'll also be kind of readdressing some of this about, what to think about when school is coming back, new teachers, new classroom, new environment. And then, as I mentioned, next week, we'll be having a similar webinar to this in Spanish. So if you know people who might benefit from being able to ask questions in Spanish and hear all of this information in Spanish, please feel free to share that. And again, huge thank you to Neurelis for supporting this series, which we think is a really important way of continuing to talk about how important this is. So thanks everybody for joining us. Thanks, Marissa. Thanks, Ina. It was really great to connect with you guys and chat today. And we'll talk again soon. Take care, everyone. Stay safe.